I'm joined today by Tara Marshall, who's clinical lead at the East Academic Health Science Network, and Daniel Hodgkiss, who's a program manager at the West Midlands Academic Health Science Network. And let's start off with Daniel. There's an amazing initiative that's going on, Daniel. Perhaps you could enlighten us a little bit about exactly what is happening.
So across the country, there is a national set of work streams, and one of those being deterioration. And in that, the focus is really around a concept called PEER, which is prevention, identification, escalation, and response. So our work has transformed around how we join health and social care together to have seamless transition of patients who are at risk of deteriorating across the whole country. Each region have tackled that in slight variation, but quite a degree of standardisation in the sense of working with care homes, working with acute trusts and non-acute trusts, and then focusing on how you build networks to strengthen patients' sort of transfer.
So, Tara, I suppose the thing is then, it's going to be difficult. How do you bring networks together to make something like this happen?
So what we do is look at our main stakeholder groups. So we have our acute hospitals, our non-acute hospitals, as Dan has said, but also our care home managers, our commissioners, and the staff that work in them, who are incredible, and try and bring those together in one place so that we can start helping them to develop what they need in their area, because each area is demographically different. Across the Eastern region, we've got a very large platform to work on. So geographically, some of our hospitals and our care homes are centred a long way from each other. So it's, you know, do we find the right place to bring those people together in the same area? And that will be different across the regions. So there's 15 of the academic health science networks, of which all of them have a patient safety collaborative. And within that is a deterioration workstream lead, which Daniel has already talked about. And between us, we can share our knowledge across the different regions of how they're working and how we then develop that into how we can help our care homes.
Across the board then, and not just in the Midlands, has this been well received nationally?
Yes, it's a national programme. So we're looking at deterioration and the National Early Warning Score, which is already adopted by the acute trust and the ambulance trusts. GPs are starting to use that. And now we're looking at how we can get care homes to start using that as well. Some do, some don't. And you have to be mindful that some of our care homes, some will have complex patients in them. Some care homes have nursing, some don't have nursing. So not everything is going to be applicable to all of them. So the other part of that is we are introducing soft signs, which is your worry factor, your clinical concern. And the people that are looking after these patients or residents are the experts. They know them the best. So if they've got a concern, how do we turn that into a conversation that's structured with a responder such as your GP, or it might be NHS 111, or it might even be 999 services. So it's how do you transfer that worry about your person that you're looking after into a national early warning score that everybody can interpret, which we know everybody already can because we're already using it, but then have that escalated and handover taken into a structured format.
And I suppose, Daniel, as well, at the current situation with COVID-19 and the emphasis that's been put on care homes and community, this is now sort of come to the forefront, I guess.
Yeah, so there's been masses of national guidance released, and the British Geriatric Society are one of those that champion care homes being involved in deterioration-wide work streams. Because actually what we've seen with the pandemic is that there is this scope and need for care homes to be seen as part of that wider work stream, but equally then that care homes get that part of the bigger conversation. So actually that it is, rather than separate silos, in health and social care, that we have agencies all working together, that there is seamless care and treatment across all healthcare settings, whether that be a GP setting, an interaction with district nursing teams or care homes or the acute settings, etc. And I think then the emphasis there is creating a common language, so that actually we're using a national early warning score in the acute setting that's understood then in a care home as to what that means and how that can support care home staff and carers and managers, etc., ensure that patients and residents are treated and escalated in an appropriate way, so that we're not just escalating because of a worry factor. But certainly during COVID, it's heightened that emphasis, actually, you know, that we need to ensure that we've got that common sense of language, the same sort of set of tools that are being used or accessible in care homes as well as acute settings, you know, and that's really vital at the minute and moving forwards, to recognise early deterioration signs, and that links to what Tara said around soft signs management. You know, that gut instinct where actually you can't quite put your finger on at the time as a staff member or a carer, that you go, actually, I know that my resident isn't quite themselves today, but what does that look like? What does it mean? And giving them and supporting them with a tool that helps to appropriately escalate, and then communicate their concerns in a way that actually gets a response. You know, because what the last thing you want is, I've got a concern, but I don't know what to do with that.
So is that a concern for you guys, the fact that people may be aware of a situation that's happening but are not bringing that situation forward, they're not letting people know? And then the other question on that, you mentioned News 2. What other tools would you be using to support care homes?
So I guess in terms of tools, there's a range of tools. And that sort of links into sort of three sections, I suppose, in sort of my mindset. One is that national early warning score, and it is trying to integrate that into each of the settings. So we're supporting across the 15 patient safety collaboratives the use of News 2 in sort of non-acute settings like mental health trusts, community trusts, so that there's a national rollout of that. And then equally supporting and encouraging the use of News 2 in care homes. It's easier with nursing homes because they've got some of that kit and setup already, but then how we can further support residential homes. Other tools such as communication tools like SBAR, so situation, you know, explaining exactly what that resident is going through at that time, through to their background, you know, the assessment and response and recommendations of that patient or resident. And that again is used across setting, you know, so it's been tried and tested for many, many years in acute hospitals, but actually now is being used in care homes and has been now for the last couple of years, actually. And that's really important, again, to create that common thread of language. And then there are soft signs tools. So soft signs tools, there are a range of tools out there. So the British Geriatric Society have recommended the use of Restore 2 and Restore 2 Mini, which is a tool that tries to bring together, one, the identification of soft signs tools. Secondly, looks then at how we move forward with looking at an actual set of observations for residents, you know, those physical observations. But I think then equally there's other things out there like Significant 7, Stop and Watch, etc. And that common understanding of frailty is becoming increasingly important now. You know, when we understand the frailty status of a resident, we understand then how we can best care plan for that resident. So we know if a resident is deemed as moderately frail, using Rockwood or Edmonton frailty scales, that actually then we need to start having conversations with their families, having conversations with their GP or with the care home managers, etc., how we best plan treatment and care for that resident moving forwards.
And Tara, and I know you touched on it a little bit before, but what are the major benefits around this initiative? What are you getting from this? What are you gleaning from it?
So there's benefits across the whole system with this initiative, starting obviously with the resident or patient. So like Dan has already talked about how we plan care for them, but it's helping them keeping and stay in the place of their choice. So an admission to hospital can very quickly decondition a patient and mean that when they go back to their home, they have to have intense rehabilitation. They may not want to go to hospital. So it allows us to have that conversation early. If it's a medication thing that might need a tweak in their medication because something's changed, we could do that early again and ask our pharmacy team to come in and review that. And then if we look at the other parts of the healthcare system, so ambulatory care, does it relieve the pressure on them because we're not transporting our patients all over to the hospitals? It can be a very long journey to some of our hospitals from our care homes, and that will again take up services. But ultimately, as well on the acute services, if your patient goes to the ED, what our systems will do, what Restore will do, and what News will do is provide that front door with a set of observations, a baseline observation. So actually, that gives so much clinical information that you wouldn't normally have by using these systems. It's not new, it's been around for a long time, but it's new in the way that we're working with it to help the system-wide approach. So for ED, they've got a baseline set of observations, so they can treat early patients, intervene, get medication changed, or even remove medication if that's what they need to do. And then if the patient gets admitted, hopefully they have a shorter length of stay in hospital. And if we can shorten that stay, we can lessen the deconditioning, we have less rehab, patient gets home. It's supporting the care home staff to help recognise that and recognise that deterioration really early so we can get in there and help.
So in effect, judging by what both yourself and Dan had said, it's a win-win situation for everybody, for patients, for hospitals, for ICU unit, for ambulances, for everybody.
Yes. What the National Early Warning Score, because it creates is the one language across all the systems, everybody understands what everybody's talking about. So the miscommunication, the missed tweaks in handover, that doesn't happen as much as it has done before. So we're getting so much more information as the patient arrives at hospital, but equally we're supporting our care homes to enable them to actually take observations as well, so that we've got that information for us.
Would you like to add to that, Daniel?
I think it equally means that we don't have to repeat that patient story multiple times at different transitional points. You know, where we have a shared language across multiple settings, that story can be told once, and we haven't got that domino effect or that Chinese whisper where information gets lost, and that's critical then to how we treat that resident much further on in that journey. You know, so understanding a common language then it enables, much like Tara said, that where we've got an establishment of a baseline, whether that be a set of observation scores or a frailty status, that by the time the resident gets to an ED setting, that ED is much more prepared to deal with that situation. And equally then can prioritise within department the level of deterioration. So actually, if a resident has come in with a news score of 5+, which in the score of news 2 would be that we need to escalate and have some treatment pretty quickly on a patient that's triggering a 5. And actually, if their baseline is a 4, then there hasn't actually been much movement there. And it might be then that we start to think holistically about the patient. So we look wider at their comorbidities, their existing condition, and then have a much more sensible conversation around treatment and care. But equally, if you have a resident that's gone actually a baseline of 0 or 1, which actually wouldn't prompt a treatment at that point, it would be a monitoring of that resident. Actually, if they've then gone to a 7 within a short space of time, then actually it helps that setting identify we need to respond really quickly to this patient and understand how. I think understanding which areas of their observations are triggering actually also helps us to recognize that, and then couple that with the communication tool and the soft science tool. So if we know a resident actually has not been mobilizing as much as they normally would, or is that actually not eating and drinking as much as they would. Their fluid input and output has reduced for X number of days, coupled with an increase in observation. It gives a much bigger, brighter picture of how we treat that.
So in terms of the initiative itself, you guys are working in the Midlands, in the East Midlands, and the West Midlands. What sort of changes or improvements or anything have you noticed within your organisation? So we'll go to Dan and then we'll go to Tara.
So for us, we established very quickly a network that focused on community settings. So actually, previously there's been an establishment across the country around acute hospital trusts that already have existing networks. What we wanted to do was broaden that network and involve community trusts, mental health trusts, our care homes, our commissioners, and equally our local authorities. Because what we know is that our quality teams now are starting to merge. So clinical commissioning groups and local authorities that manage different elements of care homes are actually now starting to come together. And that helps conversation. So we've broadened that. And that's helped us by looking at regional escalation pathways.
Right.
So that actually we don't just have a common language, we have a common response across all areas. So we have multiple areas in quite a large region, where we've got sort of 15 acute hospitals right the way through to sort of 1,600 care homes, including domiciliary care. That then can be quite difficult trying to mesh the network and actually allowing them to come together and speak to one another and have a voice that they previously, had, but found it difficult to engage as one sort of setting. That's really important, actually, and it's transformed the way we work. So what we're doing now in West Midlands is that we're supporting care quality teams in local authorities and clinical commissioning groups to produce advice and guidance escalation maps, so that care homes know exactly where to plan their sort of response as an escalation. So do we go immediately to 999, or do we actually have a sensible conversation where we monitor a resident for a little bit longer, and we involve their GP or their district nursing teams, etc., much more, and how they use then 111 as an appropriate response, or emergency dentistry, because what we know is that oral health is becoming majorly important for care homes, and something that adds to chest infection rates and pneumonia, but actually if we get that right and we start allowing care homes to not have to struggle or panic to know where to escalate or how to escalate, that we've seen a major response from our care homes. And we've done multiple events across the West Midlands that has brought some of that teaching together, and then allowed care homes to go back and almost implement some of the tools, knowing that there's a regional set of support there to give advice and guidance along the way.
Tara?
I think for us, we've done a similar thing. The other thing that I've focused on since I've been at Eastern is a piece around the complex patient with a tracheostomy or that's ventilated within the community. And again, brought the teams together that are from the acute services, community hospitals, and equally our domiciliary care together, so we can talk about what we need for those patients, and like Dan has said, how we escalate those patients appropriately to the right people, so we've got the right people responding to the right patients at the right time. We've held a couple of these events now across the Eastern region, and have just launched a whole training package to support. It could be, a parent of a child with a tracheostomy. Equally, it could be somebody with head and neck surgery that's not long discharged from hospital. So there's a big range of patients, low in number, but very high in impact on how they use the services. And equally, because we've got such a big area, our patients can sometimes be transferred from a London hospital. So it's really important to start using tools like SBAR to make sure we don't miss information for those. And we'll still be launching the same tools. So we've got a complete community competency package for those patients. and how we look after them and respond to them when they do deteriorate. So we look at deterioration and response for them.
And I suppose to summarise, sorry Dan, if you wanted to jump in, yeah.
Sorry, the sort of latter point that I'd add to that is that previously in deterioration work streams, we focused our efforts around sepsis management, whereas actually the bigger change now with PIA and looking sort of cross-setting is that we're now looking at all types of deterioration, whether that be an acute deterioration, much like sepsis or a pneumonia, or equally a functional deterioration. So if a resident has a fall in a home, that's equally then going to establish a level of deterioration for that resident, especially if they fracture or they end up with a bleed, an internal bleed, etc. You know, there's a functional deterioration of that resident at that point. And using all of these tools combined really supports then resident planning, not just for something as significant as a pneumonia or a sepsis or a COVID, but equally then looking at those lesser injuries that actually can still cause significant deterioration and concern.
To summarise then, obviously it seems to be working where you guys are, you're very passionate about it, but this, to make it work, takes a lot of commitment from all those concerned, and it seems as though that's happening in your areas.
I think for all of us, I mean, COVID's been really difficult for us all to cope with and deal with, and how we've managed it nationally and regionally and locally. But I think the good thing that comes out of it is it does pull all of this work together, and equally pulls all the people together to start thinking about how we do standardise, how we get this information out to people. For us as the Patient Safety Collaboratives, we're here to help wherever people are, because we have coverage across the whole country. So if we don't know somebody in ours, we'll know somebody in somebody else's. So we can actually reach out to people as much as they can reach into us. And I think what COVID has done for us is to just demonstrate the opportunities that are there for some of this work to be escalated really quickly, for us to absorb some of the hardship of getting this work out, so we can help people to do that, to bring people together with one common language, but it's not a COVID language as such, so there'll be a post-COVID time, and it allows us time to celebrate what we have done well out of it. And the National Early Warning Score is one of those, although it's been around. There's lots of things that are going to come out of COVID that we can learn about at the end. Certainly how we celebrate our care home staff that have done the most amazing work throughout this. You know, we really do need to focus some more on them and how we support them with some more of these tools. And what this work will do is help us to do that quickly for them as well.
Daniel?
And for us, it's, you know, that sharing of information. So each of the work stream leads, so there are 15 of us across the country, come together. And during COVID, we've been coming together much more frequently so that we can share practices that's going on in one area, and that can be shared then with the other 14 areas. So there's many examples pre-COVID and during COVID where the work stream leads for deterioration come together and they can support, actually, if there's a concern or a risk in our area, is that reciprocated in other areas, and how are we working to manage that, you know, concern. But equally, where there is celebrating success, how do we share that then across the country so that we don't just establish something that's the same, but we adapt that tool or that approach to how it would work within our region. And there's some lovely examples of that across the country. So I think, just to say, I wouldn't say it's just working in Eastern and West Midlands. I've seen examples of where that's working across the country, and it's really quite nice to see that we have that standardised approach, that commonality, not just between healthcare settings and social care settings, but equally between us as a patient safety collaborative at that regional and national level.
It's been a fascinating and interesting conversation with the both of you. Tara, I'm sure people watching this will want more information, because obviously we can't cram everything into what we're doing now. So how would other people, or other people that want to get involved, how would they do that?
Well, we can provide you with all the links that will go up to our national website of all the tools that are available. I'm sure most of us will be able to provide you with our personal contact details as well for people that want to contact us specifically in a region. So I'll send those to you so they can be on your NULEX site, and you can just share the link out, and then everybody will get the same information.